Okay, we come to colorectal cancer now, and the first speaker is Felix Samadder aus Utah. He has the unique opportunity to have a cancer registry in Utah since 1875 or what, 1890. So he has a lot of data he can use for his studies. Please, floor is yours.
Great. Thank you, everyone, for inviting me to come talk today. So the title of my talk is Hereditary Colorectal Cancer, Diagnosis, Screening, and Prevention. Oh, should I put... So my disclosure slide, nothing to do with hereditary cancer syndromes at all. So a brief agenda. So we'll talk about the familial GI cancer syndromes, look at the evidence for screening and cancer prevention in this population, and then really I'll move into just at least briefly giving you an overview of why Utah has played historically a strong role in familial cancer research and some of the unique resources we have there. Maybe I'll even convince someone to move from here to there. So in terms of colorectal cancer, this pie chart basically reveals what are the major causes that we think about. So sporadic, which means that we have no one identifiable reason. It's a combination of genetic and environmental causes. Accounts for the largest group of colorectal cancer, 70%. However, the monogenic syndromes, where there's a germline mutation in a single gene that's either autosomal recessive or autosomal dominant inheritance, plays a role in about 5 to 7% of colorectal cancer. As you can see here, this is Lynch syndrome, which we'll talk about today, familial adenomatous polyposis, and then a related recessive entity called MYH-associated polyposis, and very rare, which are the hamartomatous polyposis conditions such as Poites-Jäger's and juvenile polyposis, Cowden syndrome. We won't really touch on them today. The final group we'll talk to at the end of the presentation is one that's most interesting to me, which we typically refer to as common familial colorectal cancer. This is where there's no one single gene that's abnormal, but there's clearly a familial pattern with first or multiple second-degree relatives in different generations being affected. And this accounts for 25 to 30% of colorectal cancer. So what are features as clinicians that we see that bring up the thought that there's a hereditary cancer syndrome? So this is young age at diagnosis. Individuals with more than one primary cancer, when we see multiple generations affected, or the presence of specific cancers clustering together, for example, colon and endometrial cancer in Lynch syndrome, and the presence of rare cancers such as ureteric cancers in Lynch syndrome, hepatoblastoma in FAP. This chart here just gives you a brief overview of what is the risk of colorectal cancer in some of these syndromes. So I'll go through in details for FAP and Lynch syndrome in the next several slides. But you can see in FAP, if left untreated, the risk of colorectal cancer is nearly 100%. In Lynch syndrome, it depends a little bit on what gene is mutated, but the risk can extend up to 70 to 80% lifetime risk of colorectal cancer. Poites-Jäger's and juvenile polyposis have about a 40 to 50% risk of colorectal cancer, and Cowden syndrome, which is more like a 10 to 12% lifetime risk. So talking about familial adenomatous polyposis. So the incidence is 1 in 10,000 live births. The adenoma penetrance is 100%, with onset of polyps usually in their teenage years. 16 years is the mean age. Sorry. Colon cancer risk is 100% if left untreated, with the average age of diagnosis for CRC being 39. It's autosomal dominant and caused by a mutation in the APC gene. In general, for clinicians at the time of colonoscopy, the recognition of the phenotype is easy as they present with hundreds to thousands of polyps in their colorectum. This is actually an indication that we're seeing more and more often for referral to our high-risk clinic. This is referred to as CHIRPY. This is congenital hypertrophy of the retinal pigment epithelium. It's gray to black clusters or spots that occur bilaterally in the eyes that are noted at the time of a dilated fundoscopy examination, which is often done for an unrelated reason in a child who's not well performing at school or is sleepy or has a sleepy eye. And if ophthalmologists see this, they will refer into our clinic as well for assessment of FAP. So Utah has a strong history of research to do with FAP, both from the description of FAP or attenuated FAP and what's colloquially referred to as Gardner syndrome. So Eldon Gardner was a geneticist at Utah State University and worked with Randy Burt, who is one of my mentors at Utah, and they described a large kindred or family with attenuated FAP and a number of extraintestinal manifestations such as osteomas, which are bony growths that occur often around the mandible or skull. Bussey was a pathologist in Great Britain who described it previously in autopsy specimens. And then the group of persons above here, you can see Walter Bodmer, Ray White, Randy Burt, and Bert Vogelstein all played an important role in the identification of the APC gene on chromosome 5. So all of this was happening around the same time in Utah. So if we can play the video. So if you can click it. Oh, go back. Try and click on it. Oh, it's not working. Okay, so what I was hoping to show you in this video, but it didn't seem to have linked properly, is a 35-year-old male who underwent a colonoscopy by myself and was found to have hundreds, if not thousands, of polyps in the colorectum. This is actually a patient who's derived from the Gardner syndrome family that was originally described by Randy and Eldon Gardner, but decided never to get follow-up or initiate screening. So from a well-known family, but never got screening. Presented at 35 with rectal bleeding and was found to have severe polyposis of the colon and actually had a rectal adenocarcinoma with positive lymph nodes that led to having an ileostomy and then chemoradiation therapy. So yeah, it's very important to understand your family history and get appropriate genetic testing. That was kind of the story. And this is another view of his colon. You can see here just the numerous polyps. This is another child that we diagnosed recently with FAP with just littering of their polyposis. So the screening recommendations in FAP include initiating colonoscopy by age 12 and repeating every 1 to 2 years. Even after you have a colectomy, oftentimes there's a small amount of rectal tissue remaining, and the advice is to have a flexible sigmoidoscopy, which is a shorter scope, every 6 to 12 months. You'll see in the next few slides that duodenal cancer has become a major cause of morbidity and mortality in this population now that most patients undergo a colectomy in their teenage years. And for this, we don't have a lot to offer, but upper endoscopy, which is a scope, a gastroscope going down your mouth into your stomach, and then a special camera that looks out the side of the scope to look at the ampulla where the bile duct and pancreas duct exit, starts at age 25 and repeats every few years. There are also guidelines for thyroid examination, and then in pediatric patients between the ages of 0 and 5 with FAP, there's a risk of hepatoblastoma, which is a very rare liver cancer, and there's guidelines recommending hepatic ultrasound and alpha-fetoprotein measurement. I'll go through the evidence for some of these. So most of the evidence for colorectal cancer screening and surveillance in FAP comes from various national polyposis registries. This is probably the most recent study, which is from the Denmark National Registry, which looked at 434 FAP patients and compared them, they're called call-up patients, meaning the ones that are in the actual surveillance program, compared to their family members who are the probans who are not part of such a surveillance regimen, and basically showed a 63 to 66% reduction in CRC incidence and mortality in the surveillance group compared to the probans in that family. Ultimately, though, FAP patients will develop enough polyps that they go on to surgical management. Generally, surgical management is offered at the time you form over 40 adenomatous polyps, or if the adenomas are over 1 centimeter in size, making them more difficult to remove, or they have advanced histology, so either villous or high-grade dysplasia. The two surgeries that are typically offered are an ileorectal anastomosis, where a small portion of the rectum is left intact. The benefit of that is often patients will have less fecal urgency or incontinence by leaving about 10 or 20 centimeters of rectum intact. However, the negative is that you continue to be at risk for rectal cancer, and therefore they need to ensure they are having endoscopic surveillance of the rectum every 1 to 2 years. And there's a consideration for Sulindac, which is a non-selective NSAID for chemoprevention of the rectum. The other surgery is called a proctocolectomy with ileal pouch anal anastomosis. So this is often referred to as a J pouch. You might have heard of it in that way. The entire colon is removed down to the anal mucosa if possible, and essentially a synthetic rectum is created in the shape of a J. The benefit is your risk of colorectal cancer is nearly 0% in this group. You still may need occasional surveillance if there's a small amount of rectal cuff tissue remaining. But the negative is you will often develop complications such as pouchitis or more incontinence symptoms as you don't have a natural rectum. FAP is characterized by several extracolonic cancers, the most important of which are duodenal cancers, for which patients have up to a 15% lifetime risk, and then lower risks of ampullary, thyroid, gastric, brain, and liver cancer or hepatoblastoma. Do you want to try this video? If it doesn't work, well, maybe I'll play them all at the end during the discussion. Maybe we'll play them at the end. I'll relink them if they're not working. Yeah. So I'll come back to the video hopefully at the end, but it basically shows what ampullary duodenal cancers look like in FAP, and unfortunately we have no great way to intervene on them without a risky procedure where, in this case, through an endoscope, we essentially cut off the entire ampulla and have to place in plastic straws or stents into the bile duct and pancreas duct to prevent them from getting complications from that procedure. So, duodenal carcinoma or cancer development has become an unmet need in FAP because after you've had a colectomy, undergoing a Whipple, which removes the duodenum, can significantly alter your ability to survive and have adequate nutrition. Sulindac, which is the non-selective NSAID I spoke about earlier, does not seem to have a strong effect in the duodenum in preventing development of cancer. And so some of the preclinical work that was done at our institution showed that part of the reason Sulindac may not work is that APC inactivation in the small bowel upregulates both COX-2 and the EGF receptor pathways. And therefore we designed and recently completed a double-blind randomized placebo-controlled trial of Sulindac and erlotinib, which is an EGF receptor inhibitor in FAP versus placebo in FAP, and found, just to summarize the result, significant prevention or regression of duodenal neoplasia in FAP compared to the placebo group. Statistically, at the interim analysis, after 66 patients were enrolled, it was so significant the National Cancer Institute ended the trial early. So assuming that the journal, which I won't specify, accepts our 150 revisions they've asked for, we'll have it in press soon, we hope. And hopefully that will impact this area of duodenal neoplasia in FAP. This is one of the patients on that trial, and you can basically see the blue area is a site of tattoo. It's basically how we segment the duodenum to look at the same area pre and post therapy. And the little white splotches are the types of polyps that you get in the duodenum. So unlike the colorectum, you don't form large pedunculated stalk-like polyps. The polyps in the duodenum are very sessile or flat, making them very hard to treat. And this is after 6 months of therapy with the Sulindac or erlotinib, looking at the same area, nearly complete disappearance of all duodenal polyps or neoplasia. So we'll go on to Lynch syndrome at this point. So Lynch syndrome often presents with colorectal cancer at an early age, with the average age of diagnosis being 44 years. The lifetime risk of CRC can be up to 70 to 80% depending on what gene is mutated. They can present with synchronous colon cancers, which means 2 colon cancers diagnosed at the same time or within 6 months of the first diagnosis. Oftentimes these cancers are right-sided. In many academic centers and throughout the entire state of Utah, we're now offering universal screening for all colorectal cancers with immunohistochemistry. So in Utah, uniquely, we have 2 health systems that account for 90% of all care, 90% of all cancer care for sure, and all tumors, endometrial and colorectal, have immunohistochemistry performed. If that's abnormal, it generates an automatic referral to the One Genetics clinic at Huntsman Cancer Center. Lynch syndrome also has a number of extracolonic cancers, which we'll briefly talk about. Endometrial cancer, which is the most important, which has a 40% lifetime risk. Ovarian, renal, pelvis, ureteric, stomach, and small bowel cancers are other extracolonic neoplasia. Lynch syndrome is an autosomal dominant genetic condition. The genes involved are called DNA mismatch repair genes, and there's 4 known genes that are involved in keeping the fidelity of your DNA stable during replication. The 2 most important ones in terms of penetrance and conferring the greatest cancer risk are MLH1 and MSH2. So you can see here the various extracolonic cancers and the risks quoted, endometrial being the most important, which has a 40% lifetime risk. So the screening recommendations in Lynch syndrome are to begin colonoscopy starting at age 20 and repeating annually. I'll show you some evidence for this, as well as for something that's being offered more and more often now, which is referred to as chromoendoscopy. Endometrial and ovarian cancer screening. Right now, we advise women to have transvaginal ultrasounds, endometrial biopsies, and CA-125 annually, starting after age 35, but there's no evidence to support that. However, prophylactic hysterectomy and bilateral oophorectomy, as I'll talk about, does have strong evidence supporting it and is advocated after childbearing is completed. The last thing we'll talk about within Lynch syndrome, at least, is chemoprevention with aspirin. We are at least advising patients at this point that this is an option, and there's some evidence to support it that I'll show you, though the dosing you'll see is much lower than what's been shown in prior studies. So we're using 81 to 100 milligrams in general. So the evidence for colorectal cancer screening in Lynch syndrome comes from at least 10 different studies, and I'll show you the one here from the Netherlands, which basically shows amongst patients who are in a no surveillance group versus a surveillance group, the incidence of colorectal cancer is much lower and was statistically significant, and this is out to 30 years of follow-up. Chromoendoscopy has come to light in Lynch syndrome, as well as some other conditions such as inflammatory bowel disease, and helping to detect polyps or dysplasia in the colon. It's where, at the time of colonoscopy, we instill in blue dye, indigo carmine is the common one, into the colon, and it helps highlight the polyp as well as the surrounding extent of the polyp in the colon. So you can see here, under white light endoscopy, this is the normal colonoscope shining white light in the colon. It's very hard to see this polyp, but once you've irrigated or washed that area with the blue indigo carmine, it's much more easily or readily appreciated. And similarly here in the lower picture, you can see the polyp is much more well appreciated. Extracolonic cancer screening in Lynch syndrome, the best evidence comes for endometrial and ovarian cancer. So in brief, this was a New England Journal study that basically took 102 women with Lynch syndrome who'd undergone a hysterectomy and oophorectomy, and 210 matched Lynch syndrome controls without surgery. And as you'd expect, the people who had surgery had no incidence of endometrial or ovarian cancer compared to the no surgery group. So this trial was actually stopped early, or the data was written up early for this study because of the significance. Okay. Chemoprevention in Lynch syndrome is now, I think, coming to a point where we can utilize it in clinic. So this is the results of a British study, the CAP2 study by John Byrne, which randomized patients with Lynch syndrome to either 600 milligrams of aspirin versus placebo, and showed a nearly 60% reduction in colorectal and other Lynch syndrome cancers, but only after 5 years of continuous use. So you can see that in the curves, they were statistically significant. The red group is the aspirin treatment group versus the blue, which is the placebo group, and you see the higher incidence. However, it took at least 5 years of continuous use. 600 milligrams of aspirin is a lot, and you develop GI toxicity at that level, such as peptic ulcers, strokes, and that's why I gave a caveat at the beginning that if we are recommending it to patients, it's usually at a much lower dose of 81 to 100 milligrams a day. So the equivalent of a baby aspirin that's used for cardiovascular risk prevention. That in itself is not evidence-based, but in a group that's highly willing to do things to prevent cancer, it's had good uptake. The last thing I'm going to talk about is common familial colorectal cancer, which accounts for 25 to 30% of patients with CRC, and is where there's no one monogenic cause, but there is a family history of colorectal cancer in first or second degree relatives involving subsequent generations. This group of patients is obviously very important as it accounts for 30% of CRC cases, and such that most national guidelines do include some statement about common familial colorectal cancer. So this comes from the American College of Gastroenterology guidelines, which advocates that first-degree relatives of patients with colorectal cancer or advanced adenomas diagnosed below the age of 60 should initiate colonoscopy earlier, so either at age 40 or 10 years before the youngest index CRC in that family, and repeat every 5 years, whereas the general population guidelines in the US is to start at age 50 and repeat every 10 years. I've circled or made this in red as I'll show you some evidence that really the studies don't support this age stratification at 60, and maybe future guidelines will revise that. So this is something where Utah has been able to play a strong role in assessing familial cancer risk or common familial cancer risk using what's referred to as the Utah Population Database. So this is a database that provides a unique ID number for every person who lives in the state of Utah and allows us to follow them through marriage, divorce, having children, their genealogical records, cancer development, and importantly, access to any health care in the state. So the pieces of data that go into the population database are the genealogical records that were originally from the LDS Church's Family History Library, Department of Health records including birth, death, marriage, and divorce certificates, cancer registry records. It's part of the SEER network, so every single cancer in the state must be reported by law to the Utah Cancer Registry. Social Security death records, driver's license records, which allow us to understand if you're immigrating out of the state, as well as your body mass index. And then most recently, in the last 5 years, all electronic medical records from the University of Utah Health Sciences System and Intermountain Healthcare, which accounts for 80% of care in the state and 90% of all cancer-related care in the state, has been integrated or linked into the Utah Population Database. So this strong collaboration or linkage between genealogical records, cancer records, and electronic medical records has allowed identification of a number of genes, cancer predisposition genes in Utah, including the APC gene for colon cancer, BRCA1 and BRCA2 breast cancer, the P16 gene mutation in melanoma pancreatic cancer. And just as an example of how the genealogical records have been useful in studying FAP patients, this is one of the original attenuated FAP families, kindred 353 in Utah. They were able to follow it up to a common ancestor up here and follow it back down to another kindred, which had the same mutation, is obviously related to the same ancestor that lived in New York, in Rochester, New York, and was being followed by a gastroenterologist there. Interestingly, when they followed it up here into the 1500s, they were able to find out that the ancestor, which is the founder attenuated FAP gene mutation that came over to North America, came from Great Britain sometime between 1624 and 1640. So that tells you an idea of the power of these genealogical databases. Something else we can thank Great Britain for. So familial CRC risk using the Utah Population Database has been one of my interests. So we've been able to look at probands with colorectal cancer and then explore the risk of colorectal cancer and adenomas in their first, second, and third degree relative. These are similar to studies that have been run out of the Swedish genealogical database by Dr. Minsky here. So what we found is that first-degree relatives of CRC probands have a 1.8-fold elevated risk. Second-degree relatives is like your aunt or uncle would be a 1.3-fold elevated risk. And even your third-degree relative, which is your first cousin, has an elevated, 15% elevated risk of colorectal cancer. As you can see, it fits with familial relationship, meaning the further you are in your relationship status, the weaker the association is. But again, it's clearly genetic and is statistically significant. does age of the proband matter? This has been one of our things. In the US, they use this age stratification of less than or greater than 60 to advise the timing of colonoscopy and the repeat interval. And our data has clearly shown that risk is elevated the highest, obviously, in first-degree relatives of young onset CRC cases. So along this axis, less than 40, 40 to 50, 50 to 60, and then all the way up to greater than 80 is the diagnosing age of the proband with CRC. And then what's the risk in your first or second-degree relative? And you can see here the risk is highest in a first-degree relative of a young onset CRC case, but it continues to be elevated, 1.7-fold elevated, even in the relative of an older onset CRC case over age 80. One could try and make the argument that right at age 60 is where the risk falls from above a 2-fold point estimate to less than a 2-fold point estimate. Though I think the majority of data favors that risk is a continuum. There's no one age at which risk just falls off. And 60 is a number that maybe clinicians picked at one time to dichotomize the data, but I'm not sure it makes sense. So in summary, I've talked to you today about hereditary colorectal cancer, 5% of the monogenic syndromes that confer a very high risk of colorectal cancer, anywhere between 70 and 100%. However, a larger portion of the pie, 25 to 30%, are people who have common familial colorectal cancer, where there's an approximately 2-fold elevated risk of CRC. Prevention should be our primary goal. Genetic testing when appropriate. Cancer screening is effective and is evidence-based, at least for colorectal cancer in these high-risk syndromes. Improving compliance with screening is important. It's something I haven't shown you here, but we've shown in our own data that even patients with FAP in Utah who have access to genetics and genetic counseling and at least 2 big cancer centers, only 54% of those patients were compliant with colorectal cancer screening. And then the last thing I'll leave with, I think the time is beginning to be right for chemoprevention in these high-risk syndromes. So obviously it's a team that does this, not just me, but obviously Randy Burt is my mentor, a number of people at the Huntsman Cancer Institute, the Population Database, and then collaborators at Intermountain Healthcare. So to try and convince you to come work with us. So this is a picture of the Huntsman Cancer Institute. It's built beside or right into a mountain. They actually had to blast part of the mountain to build the clinical addition over here. But it's a NCI designated comprehensive cancer center that covers 4 or 5 US states coming to it. There are no other cancer centers for these states. It's located adjacent to the University of Utah Hospital and is both a research center, which is over here, and then connected to a clinical full-service cancer hospital, which has its own ICU, operating rooms. And probably like many governments, government funding is decreased over time, and so really philanthropy has picked that up with over $400 million in donations from the Huntsman family to help realize this goal. So, thank you.
Okay, are there any questions?
This is really a fantastic database that you have over there in Utah. My question is, do you have also the possibility to link your data with a history of colonoscopy? We looked at these associations in our big case control studies here, for example, the DUC study, where we found increasing confounding by history of colonoscopy. So if we not adjust for that, we get relative risks for first-degree history of colorectal cancer in first-degree relatives of 1.7 or so, and this increases to 2 or higher if we adjust for colonoscopy or history of colonoscopy, because these people are aware of their increased risk, do have more often colonoscopies and so on. And if we adjust for a history of colonoscopy, we also do not see this age gradient at all. So we see this 2-fold risk approximately across all ages. So I was wondering whether this is adjusted for history of colonoscopy in your data.
So it's not. Those estimates are not. That's a great idea. It's only in the last 3 to 5 years since I got there that we've had the colonoscopy data brought in. So we can adjust for it now. So that would be a new analysis that we could do. So we have large data files of basically every colonoscopy that's done in the state going back to 1996, whereas obviously the cancer and the genealogical data goes back much further. But we could do an adjusted analysis at least for those years. So that's a great question.
Thank you for the... Hello? Thank you for the nice talk. So the observation that women with Lynch syndrome are almost as high likely to be diagnosed with endometrial cancer as colon cancer. So what does that say to you about the endometrium, or about estrogens, or about women?
Well, it means that, at very least, it means that it's something we didn't appreciate before. We always seem to concentrate our efforts on colorectal cancer prevention and screening. From a programmatic point of view, so all endometrial cancers now are getting immunohistochemistry done, as we know that, similar to colorectal, that about 5% of endometrial cancer will be linked to probably Lynch syndrome as a cause. What were you trying to get at, Polly? What other thing were you trying to get at?
I don't really know. Men don't have years.
That's true.
I don't know. I don't know.
Yeah.
Except that there must, that the colon must be a hormonally responsive organ.
Yeah.
Thank you for the great talk and the fascinating UPDB database. I have a question regarding the generalizability of the data generated or the information generated in the Utah, which is mostly based on the Mormon ethnicity, and whether there's a difference between that, the characteristic that you see for the colorectal cancer or FAP with the other population, and what percentage of the population in the Utah is Mormons and what percentages are non-Mormons?
So in general, in Utah, the population, 60% of the population of the state is Mormon. It drops in the bigger urban center of Salt Lake City to less than 50% is Mormon. The data is likely generalizable to white European populations, since that's what the majority of the population is. So, but that same statement could be made for a number of studies of the groups that are studied don't include large ethnic populations. We do account in the analysis for LDS status, or belonging to the Church of Latter-day Saints, which is the Mormon population. That does confer slightly different behaviors. So typically, if you are part of the LDS Church and you follow its doctrine, you wouldn't smoke cigarettes or drink alcohol. So the analysis does try to account for that.
Okay, and do you have the proportion of non-Mormons in the genealogical data? I mean, do you have the genealogical data of the non-Mormons?
Yes, we do. So we do. So the way it worked is in the early 1980s, the LDS Church provided the University of Utah with a copy of all of its genealogical records up to that point, 1980. So obviously, the records for people third, fourth, fifth degree relatives away, going back multiple generations, are largely Mormon. However, since 1980, any birth that occurs in the state of Utah, a copy of the birth certificate goes to the Utah population database and is added as part of family structure. So even if you are not Mormon and you're born in the state of Utah anytime after 1980, that data is included within family structure. That probably limits it to 1 or 2 generations, obviously, for non-Mormons and to first and second degree relatives. Whereas going out 5 generations or multiple generations and 5 degrees of relationship is limiting more to the Mormon population and data from the church. So,
thank you.
Thank you. Very nice talk. I was interested before in how do you say the non-genetic risk factors in Lynch syndrome, and I wondered if you could see in your data in Lynch syndrome families between the Mormons and the non-Mormons if the modifiable risk factors matter in the risks you see between these groups.
So we have not done that. What we are doing as we speak right now is we're applying the Amsterdam criteria to the Utah population database to identify families that meet Amsterdam 1 or Amsterdam 2 criteria. And so we can look at that analysis to look at behaviors. Amsterdam 1 or 2 criteria is not perfect for Lynch syndrome, but it probably is at least an approximation of the type of thing you're getting at. These very high-risk families and whether certain environmental modifiers, smoking, alcohol, which would be different possibly between LDS population and specifically LDS population that's had a baptism and an adult endowment, meaning they're compliant with the church's doctrine, versus the non-LDS population or the LDS population that didn't get endowed as an adult. So I think we'll have some data on that hopefully in the next year.
Maybe I've got 2 questions, one concerning the clinic and the other concerning the genetics. Clinically, you mentioned that there is the option for the patients to undergo CA 125 and sonography screening. Also, there is no evidence, as you pointed out. In our hands, we even tell patients, at least the BRCA carriers, that there is not even no evidence, but this is not effective, and we don't offer such a screening anymore because they feel wrongly secure or so. And we think it's important for patient decision aids and so on to make this clear so that they can make an appropriate decision. And the second question was concerning the association you showed between the degree of relationship in the family and the relative risk, and looking how this is going down with a degree. I was wondering if this is an indirect indication of an oligogenetic trait. Maybe this is also a question for you, Doug. The data, I think, somehow suggests to look for oligogenetic traits. Yeah.
The second question, I agree 100%. The fact that you see this decreasing effect size in second and third degree relatives, but often that is also getting at some aspect of shared environment. I think that's one of the benefits of my bias of the family familial risk studies, is it not only incorporates some genetic elements that are shared, but also shared environmental aspects that these families grow up with and how they both play or interplay with each other in producing a risk estimate. Your first question about Lynch syndrome, I agree with you 100% that most of our patients do not undergo transvaginal ultrasound and endometrial biopsy, and I think that's exactly what you said, what you mentioned, that by the time they've discussed with myself and usually one of our gynae oncologists, they understand that there's no evidence, and whether endometrial biopsy or the sonography test will really capture early endometrial cancer is unlikely. And generally speaking, we will try and, once their childbearing time is done, push or advocate for hysterectomy and oophorectomy, and that is the route that most patients go.
Yes, please. So, there's the microphone coming.
So great. So there are a lot of SNPs also for colorectal cancer, and I mean logically they ought to be quite useful in terms of determining, who would be eligible for colonoscopy versus sigmoidoscopy at what age. Has that been considered at all?
I don't know of any studies that have done it in the same way you've shown for breast cancer, but I think you're 100% right. It would add into a model, right? As you said, in breast cancer, family history doesn't add very much, whereas in colorectal it does. So if you added a SNP analysis on top of that, you could further refine the risk for any one person and advocate for colonoscopy and the age at which to begin, and even the intervals. Right now we have an one-size-fits-all, basically, definition.
I guess sort of related question, I mean, to what extent the criteria for whether to start at 50 or 60 or whatever, I mean, how much of that is
evidence-based?
Evidence-based, yeah, yes. Exactly.
So the evidence-based for starting 10 years earlier or at age 40 and a repeat interval of 5 years for those with a family history and a first-degree relative for CRC has very weak evidence. We basically, we know that first-degree relatives of CRC patients seem to have nearly a twofold elevated risk, and that the average age of CRC presentation is earlier, even excluding for the monogenic, the small percentage of monogenic syndromes. And from that came this idea of starting at age 40. The repeat interval of 5 years has really no evidence other than people thought. I think experts thought probably around a dinner meeting somewhere that a twofold elevated risk meant we should half the interval from 10 years to 5 years. The only studies that really support that reduced interval is there's a New England Journal paper from Andrew Chan's group at Mass General in a subgroup analysis, and he didn't have sufficient power. It's in the supplemental tables of that article, basically showed that colonoscopy was not effective for the entire 10-year period in reducing CRC risk in people with a first-degree family history. And we have a paper now in review at Annals of Internal Medicine, which is a different design. It's an observational retrospective cohort study, but it basically we had a cohort of 180,000 persons who'd received a screening colonoscopy in Utah between ages 50 and 80, of which about 8,000 persons had a first-degree relative with CRC. So in comparing those two groups, meaning 170,000 persons who are average risk, got their first colonoscopy, it was negative, they seem to have a reduced incidence of CRC for an entire 10-year period. That was significant, whereas the roughly 8,000, 7,800 persons who had a screening colonoscopy event between ages 50 years to 80 years of age, and it was negative, and they have a family history of CRC, their reduction in CRC incidence peters out after 5 years. So that probably will be the best evidence from a retrospective observational study that has its own caveats of how we define a screening negative colonoscopy event. The epidemiologists will know nothing's perfect.